Hello, I'm Aaron Lohr, host of the Endocrine News podcast. In addition to bringing you the latest research breakthroughs and clinical advances from experts in the field, we talk about education, advocacy, career growth, and more from the endocrine perspective. From bench to bedside, from graduate school to practice, from the doctor's office to Capitol Hill, we talk about it all, and it's free to you. So go to www.endocrine.org/podcast or search for Endocrine News Podcast on Apple, Google, or wherever you get your podcasts.
Hello and welcome back to Endocrine Feedback Loop, a Journal Club podcast series brought to you by the Endocrine Society. I am your host, Chase Hendrickson, and would like to thank you for joining us for our third episode. Today's article speaks to a common challenge that we as endocrinologists face on a regular basis and provides data where we have relatively little information. So I'm excited for us to take a closer look at this methodology. In this paper, the authors employ actually several different study designs to collect their information, and we're excited to take a look at that with our group today. As a reminder, one of the reasons that we do this is because the goal of our podcast is to closely review study design as a part of the methodology. And in addition to looking at the results and findings and trying to understand how these affect our clinical practice. In this episode of Endocrine Feedback Loop, as usual, we'll have three endocrinologists discussing a recently published article, always from one of the Society's clinical journals. I host this podcast and am a general endocrinologist at Vanderbilt University in Nashville, where I'm an associate program director for our fellowship. Our regular contributor and expert educator today is Katie Gutenberg. Katie is an endocrinologist at the University of Texas in Houston. She focuses on pituitary disease there and is also the program director for their fellowship. And our guest expert this month is Lynette Nieman. Lynette is at the National Institutes of Health in Bethesda and is one of the world's expert in adrenal disease. And today we're going to draw on her particular expertise in adrenal insufficiency. And as is the case for each of our episodes, everything we discuss will be our opinions only and not necessarily those of our respective institutions or of the Endocrine Society. This month, we are discussing prevention of adrenal crisis, cortisol responses to major stress compared to stress dose hydrocortisone delivery. And this is primarily out of the University of Birmingham in the UK. And this article was published in the July 2020 print edition of the Journal of Clinical Endocrinology and Metabolism with Alessandro Preet and Angela Taylor as the first authors. And now Katie will start our conversation off by walking us through some of the key points in their introduction. So Katie, take it away.
Thank you, Chase. So we know that patients with adrenal insufficiency require higher doses of hydrocortisone during a major stress, such as a surgery or an illness. However, appropriate dose and timing is somewhat controversial, and current regimens are typically chosen empirically. We know that prior regimens that used much higher doses of hydrocortisone exceed current production or known production during surgery. And current guidelines focus on choosing hydrocortisone dosing based on the severity and the duration of the stressor. So we do have recommendations from the Endocrine Society. Their guidelines break down surgical stress into either major surgery, which, for example, would include cardiac bypass, versus minor to moderate surgical stress. For patients undergoing a major surgery, the Endocrine Society guidelines recommend hydrocortisone 100 milligrams IV, followed by continuous infusion of 200 milligrams of hydrocortisone over 24 hours. Or alternatively, hydrocortisone 50 milligrams IV every 6 hours. So about 200 milligrams of hydrocortisone in that first 24-hour period, and then that's tapered over 2 to 3 days. This is in contrast to patients undergoing minor procedures or moderate surgical stress. So an example of that would be a joint replacement. And in those cases, the recommendations are anywhere from 25 to 75 milligrams of hydrocortisone, again, in that first 24-hour period, and tapered over a shorter period of time, so 1 to 2 days compared to 2 to 3 days. So Lynette, I will ask you to give us some insight in terms of your clinical practice. How do you approach a patient with adrenal insufficiency and the data? What do we already know about cortisol production during surgery?
Well, thank you very much. And I appreciate the opportunity to be on with all of you on this podcast series. I think this is a wonderful addition that the Endocrine Society has made to our ongoing learning, particularly in the time of COVID-19, to be able to access these kinds of learning experiences is I think, really fantastic. So I want to congratulate you guys for doing this. So in terms of adrenal insufficiency and surgery, I'm a little bit of an outlier, at least from a theoretical perspective, in terms of how I approach this. It is true that patients will increase their serum cortisol to quite high levels, and there have been estimates of production rate during surgery as high as 200 milligrams over a 24-hour period with very severe stress of major surgery. And I think because it's known that if patients with adrenal insufficiency do not receive steroids for a period of time, they will go into crisis. And based on that, I believe that the recommendations have been made in a more theoretical way and less from an experiential or evidential basis. So there are a few papers that I think speak to the need for glucocorticoids during surgery in patients who can't produce glucocorticoids themselves, so in patients with adrenal insufficiency. And we have to remember there are these two types of adrenal insufficiency, the kind where the adrenal gland does not make cortisol, and it doesn't make cortisol, nor does it make mineralocorticoid. So in primary adrenal insufficiency, where we don't make either of the two cortical compounds, or in secondary adrenal insufficiency, more common type of adrenal insufficiency, where glucocorticoid is the only steroid that is not available. Most of the data we have are from patients with secondary adrenal insufficiency. But what we do know is that there are some papers where patients have not received any glucocorticoid replacement for 36 hours, one by Kellett in the British Journal of Anesthesia in 1973. And of those 74 patients, most of them had been receiving glucocorticoids that were certainly in excess of normal amounts, so that they were receiving super physiologic amount of glucocorticoid, but they went without any for 36 hours. And of those 74 patients, 18 had hypotension during or before surgery. But of those 18, 11 had a good reason for hypotension, such as bleeding. And of those 11 with a good reason for bleeding, 3 of them had only slightly abnormal adrenal function, even though they were on steroids. And of the remaining 7 who had hypotension, only 3 again had slightly abnormal adrenal function. So a real minority of the patients who had hypotension had any kind of abnormality. And in contrast to those 6 who had a slightly abnormal adrenal function, 33 people with reduced adrenal function had no hypotension. So these authors basically concluded that the need for adrenal supplements during surgery had not been proven because these patients did well without that supplementation. The knowledge of that paper led to some studies in the 1980s and by 90s looking at one study in monkeys who were adrenalectomized, replaced for a number of months, and then underwent cholecystectomy, at which time they had 4 days of various replacement regimens. One was 10 times normal replacement, one was 1 times normal replacement, and one was 1/10 replacement. The monkeys who received only 1/10 of a normal replacement dose for 4 days did poorly. But the monkeys who received either a normal replacement dose or a 10-fold replacement dose went through surgery without any problems. This suggests that if monkeys are a good model for people, that human beings may not require a higher than normal physiologic replacement dose during surgery. And this was tested by a paper by Glowiak and Loriot in the 1980s, I believe, in which 18 patients receiving about 14 milligrams of prednisone daily underwent surgery with their usual dose of prednisone. Now, obviously, prednisone of 14 milligrams is slightly higher than normal, but they didn't get a very high dose. And this was compared with a group of them who received 100 milligrams of hydrocortisone and followed by 25 milligrams every 6 hours. And those patients did identically well during surgery. So again, another paper suggesting that these super physiologic, very, very high doses may not be needed. And there's another paper by a couple other people in the anesthesia journals looking at stopping doses of prednisolone for 18 hours prior to surgery. And basically only 1 out of the 9 patients in that study developed hypotension. So not a very large study. Again, suggesting that it may not be necessary to give a very huge dose. And then I think finally the other thing to keep in mind is there's a lovely study by T.M. George, published in JCM in 1974. And in that paper, he showed that patients who were undergoing cardiac surgery with morphine anesthesia with 4 milligrams of morphine did very well through the surgery and postoperatively. And those patients had no cortisol increase during surgery. So in the absence of any cortisol increase in surgery, patients did very well. So I think we have some provocative studies that suggest that patients may not need these very, very high doses of hydrocortisone. Again, we don't know whether these patients had primary adrenal insufficiency, except for the monkeys. And so it's possible there may be a difference. But I think this really highlights that we need studies just to establish the need, the necessity for giving these very high doses. And why would we care about that? I think because high doses of steroids are well known to suppress immune function. It's probably important to have good immune function after you have surgery. And it may be that high doses of steroids contribute to postoperative cognitive dysfunction. And that's a big problem, particularly in older people. And so I think it would be wonderful if a group decided to study the necessity of giving these high doses. So I'll stop there. That's a long-winded answer to your question that basically is that I'm not really sure that common practice is based in evidence that shows that we really need these high doses of steroids. And I think it might make some sense to reconsider our current recommendations. But I think most of us, and I'm included in that, tend to give some dose of excess steroid over the time of surgery. I try to give no more than 100 milligrams over a 24-hour period, and I taper very, very quickly. One other experiment of nature or experiment of science that we should remember is that when we treat people with Cushing syndrome with transsphenoidal surgery and render them adrenally insufficient, we typically, at least at the NIH, allow patients to go for 3 days without any steroids. On the day of surgery, these patients are rendered adrenally insufficient. They maintain adrenal insufficiency status for 3 days. They don't, in general, have any hypotension. They don't have a cardiovascular collapse. So I think perhaps what we need to do also is think specifically about the need of people with primary adrenal insufficiency and how we can support them during surgery.
Lynette, thank you so much. I think that's a perfect overview because that really highlights exactly why we want to look at studies like this, because we're often fooled because we have these well-protocolized approaches that I think will often lead to us forgetting that we maybe don't have a very good evidence basis for what we're doing, and that we need studies like this that try, and they answer different types of questions, but try to get to the bottom of these questions of what do we need to do and how do we need to be doing it.
The focus of the current study is looking at appropriate dosing and delivery modes of hydrocortisone, and specifically looking at the difference between continuous infusion and bolus hydrocortisone. And then of note, in contrast to some of the data that you were sharing with us, this study is really focused on cortisol levels and not clinical outcomes.
And Katie, I'll ask you here, because I was curious about that, looking at the title, and perhaps a minor point, but looking at the title, the first part of it is prevention of adrenal crisis, which really does seem to imply a clinical outcome. I think what comes after the colon, the cortisol response to major stress compared to stress dose hydrocortisone delivery, that's a right-on perfect description of what they're doing. I do think we have to be a little bit careful, and interested in your thoughts here, because that first part, the prevention of adrenal crisis, very much sounds like they're going to be exploring clinical outcomes, which as we'll look at is not something that they look at in this paper.
Right, that's correct. And the authors really basically just extrapolate their information regarding cortisol levels, which we'll take a look at and kind of make assumptions about whether or not that will change clinical outcomes without actually looking at clinical outcomes.
Yeah, and we'll want to keep in mind exactly the questions that Lynette asked us to think about, which is we need to be careful as when we're making that connection is, yes, this may help us understand part of it, but there's often a bigger question of, do we need to be doing this? And if so, exactly how? So we'll certainly keep that in mind as we go on. So I'll take us through the methods section, and this is fairly involved because the authors initially start with actually 3 different studies. Now they end up, as they move on, comparing several of these studies, so it's not 3 totally independent studies, but we will look at it in that way because I think it's helpful to review it in that way. So the first study that they do is a cross-sectional study. We've looked in this series at cross-sectional studies before, so as a very brief reminder, cross-sectional studies take groups of subjects and collect all of that information at a single point in time. And in this cross-sectional study, they actually have 4 different groups of subjects that they look at. And one thing in any observational study, you always want to worry about the possibility for confounders. So as a reminder, confounders being anything outside of the immediate labeled exposure, but connected to it in a way that could lead you to erroneous conclusions. And something to think about, and we'll see how applicable this might be when we get to the results, but cross-sectional studies are particularly prone to confounding if your subjects come from completely different groups. So with that in mind, let's actually look, and they do have 4 groups in this cross-sectional study, and all of these, there were single time points in the morning where cortisol levels were measured, and the first group was 122 individuals, healthy, non-stressed controls. The second group, also healthy subjects, but it was individuals under combat stress, so 105 individuals in the military in active duty. A third group were individuals who were undergoing major trauma. So in this group, their cortisol level was measured within 24 hours of admission after major trauma, 83 such individuals. And the fourth group in this cross-sectional study were 100 individuals with sepsis. This group also had their cortisol level measured within 24 hours of admission to the hospital. And one thing that I was curious about, I think certainly the controls make sense, and then also the major stress groups thinking about trauma and sepsis. It was interesting inclusion of individuals with combat stress, because that we would not think of a typical medical pathologic stressor like trauma or sepsis. And certainly while there is a substantial amount of physical stress, you could also wonder how much psychological stress or other sorts of stress is affecting the body there. And so I was curious about Lynette's insight into the difference in these sorts of stress and what we know, if anything, about how that affects the HPA axis and its activation.
There is a body of information, of data on psychological stress. Many times these are in themselves cross-sectional studies, and they oftentimes do not use a single cortisol value as this does, but instead use very well-validated tests of social anxiety that is considered to be a psychological stressor, like the Trier social stress test, in which one has to do a performance of some sort in front of a group, and this provokes very stressful feelings in some people. The evidence for abnormal cortisols in folks who are in the military is primarily derived from training, measurement of cortisol during training of various sorts. So, for example, training to be a sniper, training that involves imitation capture as if one were a prisoner of war, and interrogation. And these are generally short-term stresses that I think one might relate more to those. One can imagine if you're in a even pretend situation of being captured and interrogated, that would be quite stressful. At least I would imagine that to be the case. The question of deployment per se is a little bit less well covered in the literature. And one of the things that concerned me a bit about that group was that they state that the blood sample was taken in the morning, but it was taken within 4 weeks of deployment to Afghanistan. And I'm assuming that they were going to Afghanistan from far west of Afghanistan, either from perhaps the UK or from even the United States. And one knows that when you cross time zones, you are going to have a different kind of cortisol at 9 a.m. in Afghanistan if you have just arrived there from the United States. So we don't know much about when that was taken in terms of their circadian rhythm and whether their circadian rhythm was normal at that point, whether they had readjusted to the deployment. And we don't know what they were doing during the deployment. So I think without additional information, it's a little hard to know what to make of that particular group. While we know that psychological stress can elevate cortisol quite substantially, it's hard to know whether this is within even that group, whether that is a homogeneous group that could be taken as representative of all deployments.
Good. Thanks for that overview. And when we get to the results section, we'll take a look at some of the particulars that we know about these groups and try to figure out how comparable they are and how much of an issue confounding might be. The Lynette's already pointed out one issue that we would need to think about. So that's the first of the three studies that they did. So moving on to the second study that they did, which was a prospective study, is how they labeled it. And what that is they took 22 individuals with normal adrenal function who were undergoing elective surgery. And in those individuals, they did repeated blood sampling, so not a single one, but a repeated blood sample over 24 hours. And in and of itself, because all of these individuals are exposed to the same surgery of sorts, so there were different types of surgeries that we'll look at, there's no control group that didn't have a surgery. So in and of itself, it's easiest to think of this study as a case series. Now they're gonna make comparisons here, so it won't end up being just that, but in and of itself, that's the easiest way to think about it. And then the third study of their three that they did was described as a randomized open label study. And this is what they did to collect their pharmacokinetic data. And the way that this study worked is they had 10 individuals with known primary adrenal insufficiency. And they brought them in and gave them 200 milligrams of hydrocortisone over 24 hours, but they did it in different ways. So their four regimens were, the first one was oral tablets of 50 milligrams of hydrocortisone. Their second regimen was intramuscular bolus injections, also of 50 milligrams of hydrocortisone. The third one was intravenous bolus injections of hydrocortisone every 6 hours. And then finally, the fourth one was a continuous infusion of hydrocortisone IV, still equaling 200 milligrams over 24 hours. And what was really nice about this, and I think this is a nice contrast to the first one, is that this was a crossover design, meaning that all 10 individuals underwent this protocol, each of the four protocols, in variable order. And so it's not that confounding goes away in crossover trials. It's just that every group is identical. And so the easiest way to think about that, again, in and of itself in this study, is that the confounders all perfectly cancel each other out. And so these three trials, the cross-sectional study, the prospective study, and the randomized open label study, will be compared to each other, and we will take a look at that in the results. Further words on the methodology, so in particular about the glucocorticoid measurement. So they look at it in various ways: total cortisol, cortisone, and then serum-free cortisol. So those are all measured with liquid chromatography tandem mass spec, and then do 24-hour urine glucocorticoid collections in some of these individuals, and that's measured with gas chromatography mass spec. And I thought Lynette's input would be helpful here, because usually clinically, for the majority of us, when we're assessing individuals with adrenal insufficiency, that it is total cortisol that we are using. So there's a couple other things that these authors use. So cortisone is one thing that they use. So curious to hear from Lynette's perspective how that's helpful in a research study. And then also free cortisol is something that they measure here, and is occasionally something that we use. But as far as a serum test, not something that is widely available. And so I'd like to hear from Lynette why these were done, and then also in particular with free cortisol, why that's not more widely available and widely utilized in these individuals.
Sure. So the cortisone is interesting. They don't explicitly tell us why they measured it, but I believe that there are some good reasons to look at cortisone and cortisol at the same time. As you all know, there are two ways in which cortisol and cortisone are interconverted. One is with 11-beta-HSD1 in the omentum and liver primarily, and that is a mechanism by which cortisone is converted to cortisol. So it's a regeneration in a sense of cortisol. And it's known that in some conditions there's some question as to whether that interconversion is altered. What's perhaps more pertinent to this particular set of studies is that cortisol is normally inactivated to cortisone in the kidney, and this protects the kidney from cortisol, which is capable normally of interacting with the mineralocorticoid receptor, and so it eliminates that opportunity for cortisol to interact. There are some conditions in which case that relationship between cortisol and cortisol is changed, one of which is in Cushing's syndrome, where there's so much cortisol that it overwhelms 11-beta-HSD2. But I think more pertinent perhaps to this is that in the ICU, a lovely set of studies authored by first author named Boonen in the New England Journal, it was shown that the inactivation of cortisol to cortisone was reduced in patients who were septic. And I think perhaps they were wanting to look at that in both the sepsis patients that they, or at least draw that comparison between the patients that they studied intensively during surgery to see whether there was a difference between the cortisol and cortisone ratios. In terms of the free cortisol assay, the assay they use is, I consider to be the state-of-the-art way to measure free cortisol in the blood using an ultrafiltration device in which the combined cortisol and CBG complex is excluded from being able to pass the membrane, and only free cortisol is able to cross, and then that can be measured by tandem mass spec. And that is a really beautiful way to do it, and I would hope that all of us will get to that at some point, because free cortisol, as we all know, is the biologically active moiety, and when we measure total cortisol, we are not always properly imagining the amount of free cortisol that's available. For example, Peter Traynor and others have done some beautiful studies looking at the fact that cortisol dissociates from CBG much more readily at high temperatures within the range that's seen in normal physiology. So when people become febrile, our free cortisol fraction is much higher than it would normally be at a normal temperature. And so there are a lot of reasons like that where you want to be able to measure free cortisol directly rather than making an assumption about it based on the total.
And to wrap things up in the methods section here, just a brief word on the pharmacokinetic modeling. And that's really where the authors are going to go as the key take-home message in their study. And this is based on that third, that labeled randomized study that they did, is that it's an analysis of the different methods of the hydrocortisone administration. And then they do this modeling to try to understand what the cortisol curves look like with these different methods of administration. And then that will allow them to go back to the second study where they did the repeated cortisol sampling and try to understand which of these modeled curves fit best with what the increased demands are in individuals who do not have adrenal insufficiency. that's an overview of the methodology. So we'll keep that in mind. We'll come back to some of these key points, and we'll turn it back over to Katie at this point, and she's going to walk us through the results section.
Thank you. So starting with glucocorticoid concentrations in different conditions of stress. So looking at cortisol levels in patients who presented with sepsis, elective surgery, or combat stress, all of those levels were higher than the controls. A couple of surprising findings, I think, were some similarities between patients who underwent elective surgery and combat stress. And then also looking at a little bit closer some of the details of the participants in the various groups. So looking at table one important thing that you would want to point out was different amounts of women in the various groups. So for example, in patients that presented with major trauma, only about 10% of patients were female, compared to patients undergoing elective surgery, where about 60% of patients were female. And they don't comment about anything regarding their reproductive status, whether they were taking oral contraceptives, for example, which, as we know, would increase their total cortisol level and could affect these results.
Yeah, and Katie, I think those are important things to point out. We mentioned earlier that concern because these are pretty different groups, and when you have different groups that make up your exposed and unexposed portions of a cross-sectional study, they are particularly prone to that. And I think we have some clues based on that table one that you're talking about, is that the percentages of females and males in each group is substantially different. Age is also a pretty big difference, as you would expect, for example, that in those individuals with combat stress, in their 20s, as compared to individuals with sepsis who are in their 70s, with the median age in those groups. And I think you can also imagine that other health status, there's going to be a big difference in individuals who are in the military as opposed to older individuals being admitted to a hospital with sepsis. So I think it's going to be awfully hard. Now, fortunately, this is not the main part of this study, so I don't think it's a deal breaker for the entire study, but I do think we have to be really cautious about comparison, because there is some unusual findings, as if we look at least at the point estimates for the serum cortisol for combat stress and elective surgeries, that they're awfully similar. But I do think we have to wonder how similar those groups are, and if really that's the take-home message here. So I agree with you, Katie. Certainly some surprising findings here that it's hard to explain and may be substantially affected by confounding.
So in terms of just continuing on looking at glucocorticoid concentrations, so there was no difference between unstressed controls and patients who presented with acute major trauma. I think some explanation for that could be that, again, these are based on single time points. Patients were admitted within 24 hours, or cortisol was measured within 24 hours of admission, and there may have also been some blood loss that contributed to that finding, because 24-hour excretion of cortisol was increased and was higher compared to the controls. The next set of results focuses on glucocorticoid dynamics during elective surgery. Patients were divided into two different groups. So those who underwent shorter duration surgeries with a median duration of 60 minutes, and those who underwent longer duration surgeries with a median duration of 175 minutes. The same general pattern was observed for both groups. So there was a decrease in serum cortisol after induction of anesthesia, followed by a gradual increase. And the peak cortisol occurred later in patients who underwent longer duration surgeries. So that peak cortisol typically occurs at the end of surgery during withdrawal from anesthesia. And the peak cortisol was observed after a median duration of about 3 hours for the patients who underwent shorter duration surgeries, compared to a median of about 5 hours for patients that underwent longer duration surgeries. And as you would expect, the serum cortisol levels remained elevated longer as well too among the patients who underwent the longer duration surgeries. And then the next part is the pharmacokinetic study. And so again, that's the group of patients with adrenal insufficiency who are receiving different regimens of hydrocortisone. So they received continuous infusion and then 3 different bolus regimens of hydrocortisone: oral hydrocortisone, IM hydrocortisone, and IV hydrocortisone. And if you look at all 4 regimens, the peak cortisol level was significantly higher after patients received hydrocortisone compared to levels that were observed in both elective surgery, combat stress, and acute major trauma. The cortisol levels did tend to be higher in patients that were admitted with sepsis. And so, Lynette, I kind of ask you to comment in terms of concerns regarding potential over-replacement in patients with all 4 of these regimens.
So even if we assume that it's appropriate to replace patients with a level of hydrocortisone that corresponds to the amount of cortisol produced during surgery by normal individuals, we would want to not achieve levels any higher in the blood than those seen in patients with normal adrenal function. And so what we are seeing here is that each of these regimens have peaks that are much higher than what was observed in the patients who are presented in the context of this study. And that makes one wonder, is this really appropriate? And I think that's where the authors were going with this, because when we look at the figure that demonstrates the cortisol levels after each of these administration schedules, one sees that there is a very dramatic difference between the peak and the trough level in those who received hydrocortisone on an intermittent basis versus those who received a continuous intravenous infusion. However, even with the continuous intravenous infusion, there is a very high level of cortisol in the blood of these patients with adrenal insufficiency. And if we compare that to the level that was seen in the patients with elective surgery, it's higher, or at least higher than some of the patients with the elective surgery. It's certainly higher than the median value that's been presented. So I would be concerned that perhaps this amount of hydrocortisone is unnecessary, even if we agree with the assumption that one wants to replicate what's seen in healthy individuals undergoing surgical stress.
So looking specifically at cortisol levels after hydrocortisone compared to elective surgery. So as you mentioned, there are, as you would expect, more peaks and troughs with patients that received the bolus hydrocortisone. So again, in the peaks, the cortisol level was higher than that observed during elective surgery. And then patients also developed trough levels of cortisol, and those were lower than the median observed in patients undergoing surgery. And as you would expect, patients who received the continuous infusion of hydrocortisone had more stable cortisol levels without peaks and troughs, and those levels were maintained above the median observed in patients undergoing elective surgery.
And with that, we'll transition into looking at the discussion. And as we usually do here, we will walk through the author's conclusion, but then we'll also give you some of our own thoughts, our own opinions on that, and any remaining questions that we have. And then where we'll end up is looking at our own clinical practice and trying to decide if these results should impact that. So based on the study and based on the modeling that they do here, the authors recommend that really the continuous infusion is going to best approach the needs for hydrocortisone replacement in these individuals. And based on the modeling that they did, they recommend that initially it needs to be an IV bolus, 50, 100 milligrams of hydrocortisone to quickly get the levels up, but then that is followed by the continuous infusion of 200 milligrams over 24 hours to most closely replicate the pattern that is seen in healthy individuals undergoing surgery. And the reasons for that, as they mentioned, primarily that it's the only one that maintains the cortisol in that observed range. And they really stress that why this is superior is because compared to the bolus, with the bolus you have these spikes and these troughs. So they have concern that with the spikes you have potentially these substantially supraphysiologic peaks that could have adverse effects, for example, hyperglycemia, and that the troughs are fairly low levels of cortisol for a couple of hours at a time. And their concern, and I'll quote them here, is that with this under replacement, that it's hence the possibility of adrenal crisis, a life-threatening complication of cortisol deficiency. And so that's where I thought we could talk a little bit more about that, is if that's having 1 or 2 hours of levels that are below what you would normally see, if that's enough to really predispose or put an individual in an area of an adrenal crisis that could be life-threatening, or if that's more of a theoretical concern, what we know about that. So I did think it would be helpful for Lynette to chime in here, really trying to help us understand that without, at least from this study, without clinical outcomes, are these information trying to match what a normal individual does? Is this meaningful data, or is it a good starting point for a study with clinical outcomes?
In thinking about the importance or the potential liabilities associated with an hour or two of very low cortisol levels associated with these troughs, one might think about how we normally replace these patients with hydrocortisone. And in thinking about that, we know very clearly that given current twice or even thrice daily replacement regimens, patients remain at very low levels of cortisol for substantial amounts of time during each day. And the patients are not going into adrenal crisis after a few hours of low levels of cortisol. Now, if one believes that there's something different about the stressors of surgery, where a patient must have very high levels of cortisol at all times to prevent a crisis, I would again turn to the paper from England with the morphine anesthesia showing that patients who have very low levels of cortisol during the entire surgical procedure do just fine. I would also refer to patients who are adrenalectomized and will oftentimes, at least in our institution, be kept without any replacement therapy for a full 24 hours. And the purpose of that is to be sure that we've gotten the entire cortisol-producing tissue, and their cortisol levels will be undetectable at the end of that period of time. They've been many, many hours without any cortisol on board, and they do fine. So one has to get back to the primary question that I think underpins this entire project, which is, what are the data that tell us that patients require cortisol levels of any given amount during surgery in order to prevent an adrenal crisis? And I think that's the fundamental assumption that's made here, that one does need very high levels consistently during surgery. And I don't personally believe that that's been shown previously. It's not that I'm sure it's not correct. I just don't think we have the data to say that it is correct, and we don't have the data to tell us how much people need and for how long a time, either during, before, or after the surgical procedure. So I think that's a very interesting, it's an assumption that's made at the very beginning of the paper. In the introduction, when the authors basically say that patients are unable to produce adequate amounts of cortisol, they require increased hydrocortisone replacement to avoid life-threatening adrenal crisis during surgery, trauma, or severe infection. And I think that's an assumption that's being made, and I would challenge that assumption and say that I think we need more information to show that that's actually true.
So we'll get into a little bit more of how we think this should affect our practice. But first, a few limitations, and these are ones that are pointed out by the authors, is that part of the issue, we've touched on it already, is that during the elective surgery group, that there was repeated cortisol levels that were measured, but during the cross-sectional studies, it was just a single point in time. And so the problem there is that it's going to be a little bit hard for us to compare the surgical group, where we have numerous measurements, to some of the other groups, in particular individuals with sepsis. And part of that is because we know, and the authors discuss this, is that cortisol metabolism has changed substantially during sepsis. And so there may be some limitation in how well we can take surgical data and then compare that response, that stress response in terms of cortisol, to individuals with sepsis and what their stress response might be. So I thought just really briefly to help us understand that limitation just a little bit more, as if Lynette can give us an overview on just a few of the changes that happen in sepsis related to cortisol metabolism.
Right. And some of that is actually shown in their paper. For example, in the figure 2, they have a graph that's looking at the ratio of cortisol to cortisone. And one can see either looking at cortisol alone or cortisone alone, or the ratio, that the ratio is increased in sepsis patients as compared to the patients in any of the other categories. Although the elective surgery patients do have quite a large overlap with the patients in sepsis, the median levels are somewhat lower. And again, that suggests that there is less there's less inactivation of cortisol to cortisone in sepsis, and we really don't have those elegant studies in elective surgery to know whether that's important. So I think there is clearly a difference in septic patients in terms of how they metabolize cortisol compared to healthy individuals. Whether that pertains also during elective surgery, I think we really don't know, and it does, I agree completely, it does affect whether you can extrapolate completely between the two different patient groups.
And for just the reasons that Lynette outlined there, obviously a good inclusion there for the authors to list that as a limitation here. And also that they point out that the surgical group had moderately invasive procedures, so perhaps hard to know with more major surgery what impact there might be there. So now what I would like us to think about is how this study in particular could change our practice and what our thoughts are overall. Before we get to the main point here, one small point I was curious about, and this is tying back to that cross-sectional study, is if we look at least at the point estimate for the elective surgery and the combat stress groups, is that cortisol levels rise by a similar amount. We would advocate usually for stress dosing hydrocortisone in elective surgery, but in combat stress or other types of stressors, we generally don't use stress dose, at least not for a prolonged period. And so it was curious for our group's input on why that might be, when at least based on this study, issues of confounding aside, the cortisol increase is fairly similar. Lynette, any thoughts about that?
Well, again, we have to wonder whether that increase is a real increase, why it's increased, what time of day it was taken, and also that sort of thing. But if we assume that these are correct, then it does, I think, pose an interesting conundrum as to why we do stress one set of people where we think that there's a need for extra dosing and not another. Now, there is potentially, and again, we're veering off into speculation here, but I found that with my patients with adrenal insufficiency, when they are extremely physically and psychologically stressed, that there are times when I do allow them to take another small dose, and I'm talking about 5 to 7.5 milligrams of hydrocortisone. And the one specific situation in which I've done that, apart from labor and delivery, where I do end up increasing the dose, and pregnancy and adrenal insufficiency is another whole topic. But the one situation, apart from pregnancy, where I've done that is when I have young patients who have primary adrenal insufficiency, and they're going to run in a marathon. So they're going to spend a number of hours with real physical stress and a certain amount of psychological stress. I don't know how well hydrated they will be, which is a concern in terms of sodium and getting hypotonic. And so I usually have them take a bit more hydrocortisone. But there's no study I'm aware of that supports that practice. This is more a clinical judgment when I've listened to patients and how they felt during their training or their marathon, and then we try the extra dose and they seem to do better. I would take that again as another very interesting takeoff point for a true study that would ask the question, do people do better? Do they have a better time? Do they feel better? Is their quality of their experience better with more or less steroid? I think that would be a lovely question to ask and to solve through a real experiment rather than sort of an ad hoc kind of intervention that I've done myself.
And I do think that some of this data does help raise those questions, because if we look and see, again, issues of confounding aside, is that rise in cortisol is the same. So do we need to be looking at it in other situations? We pretty routinely do it in surgery. Should we be routinely doing it in other stressful situations? Certainly, there's not going to be many of us who are going to be stress dosing patients in combat stress, but other ones that are having substantial physical and psychological demands on our patients. And I agree. I think this observational data from the cross-sectional portion of their study does at least raise that question of maybe we should be thinking more about that. Certainly would be interested in seeing data study to look at that further. And so I think that now we need to move on really to our main point here. So it's our thoughts overall and really how this should affect our clinical practice, what implications this has on how we take care of our patients. And so we'll start with Katie and would like to get her input, and we'll all kind of chime in on what we think as far as how this should change what we do.
Yeah, I mean, the focus of the paper was really looking at different hydrocortisone regimens. So they didn't look at different hydrocortisone doses. They didn't look at clinical outcomes. I'm not sure that the data in terms of looking at cortisol levels and peaks and troughs would necessarily be enough to recommend one regimen versus the other. I know some centers do continuous infusion for hydrocortisone. I think more frequently people use bolus hydrocortisone, and that's certainly what I use when patients are undergoing surgery. So I don't think that there's strong recommendations based on this paper to favor one regimen versus the other.
And I think when I was taking a look at this and trying to understand that, I think because you don't have the clinical outcomes, I do think you have to be really careful about advocating one versus the other. I do think what the authors do a very nice job of is demonstrating that if you want a regimen that is going to come as close as we can to reproducing normal physiology, their pharmacokinetic information data shows a great pattern and really clearly indicates what we should be doing there. And so I think that is a very, very nice feature of this study, and I think is really laudable and will have an important place in our understanding of treatment of primary adrenal insufficiency. But I do think it does need to fit in the greater context of just what Lynette has said. What Katie's also pointed out is how important is it that we reproduce normal physiology? Does that have an impact on outcomes? And also thinking about not just how we do that, but at what dose we do that. All of these doses were the same. It was always the 200 milligrams in 24 hours. And I think maybe a larger question, and this study didn't try to answer that question, so certainly not faulting the authors for not answering that question. That's not what they were trying to answer. But I do think we need to be asking that question: is what is the right amount of hydrocortisone to be giving in these situations? Lynette, what are your thoughts on what our clinical practice needs to be adjusted based on this information?
Yeah, so I actually do want to echo what you said about the modeling. I think the PK study and the modeling is really beautiful. Really very well done, very nicely using the comparative data to make their points. And so from that perspective, I think this is really excellent. I think the main question for clinicians is how should we use these data when we have a patient in front of us who we believe needs to have a hydrocortisone during surgery or afterwards. I think the first point I would make, we've already touched on, which is I think this 200 milligram dose is just too high. It does give higher than normal values most of the time. Certainly patients who are diabetic are going to have more excursions in glucose with this most likely. And I would also worry about white cell function. So I think one could use the same data and remodel at 100 milligrams and probably find that that might be a better dose. So it might be interesting to ask the authors about that. One other issue, which this paper can't answer, but I think it's something very interesting to keep in mind, and it gets to the contribution of a lot of basic science work to our clinical thinking. And that is a paper from a few years ago, I believe in Nature Medicine, with Gordon Hager as the last author and Stafford Lightman as one of the authors, in which they gave rats who were adrenalectomized replacement glucocorticoid in either a continuous fashion or as an intermittent dosing. So there were peaks and troughs. And what they found was that the type and the amount of nascent RNA was very, very, they killed the animals and measured nascent RNA in the liver and other organs. They found that the level of nascent RNA, so the newly formed RNA, was very, very different in the rats who received intermittent dosing, peaks and troughs, making the point that probably the physiologic way that we actually experience cortisol, which is not as a continuous infusion or as a bolus that lasts an hour, but as these little peaks and followed by troughs, is probably very, very important to normal physiology. So this entire paper and the way it's approaching these two major differences, the bolus versus the continuous infusion, probably both of those are totally non-physiologic. Now, whether that makes a difference during surgery, I don't know, because I don't think anyone has done the very fine, highly timed, every few minutes kinds of sampling to look at whether there are pulses of the same type in surgery. But I think that would be another interesting question to ask. Do we really want a continuous infusion? The third point I would make, though, is that there is one situation in which I would definitely use a continuous infusion, and that's the situation where a patient, for whatever reason, has very, very low CBG and very low albumin. We know that cortisol is carried around in the blood on these carrier proteins, and they serve as a reservoir for cortisol. In the absence of CBG and in the absence of very much albumin, cortisol is eliminated very quickly through the kidney. And so in that setting, if you give boluses, you're going to get a very short amount of cortisol available just for a little bit of time after the bolus. And we do occasionally see patients in the ICU who are septic, and some of those patients are also going to surgery who have very, very low CBG levels. And although the genetic loss of CBG seems to not confer major problems to people, I'm not sure about individuals who have a more acute loss in CBG as to whether or not they should be treated with bolus injection. But I think that is a very rare occurrence. It's just something, again, to keep in mind, that we want to match our treatment to our individual patient and basically personalize or choose an individual approach based on what we know about each patient that we have.
Lynette has very helpfully outlined many of the questions that we do not have answers to. How many questions there are that are unknown in adrenal disease, and particularly adrenal insufficiency. And I think really helps reiterate the point of why we need studies like this that really start to try to answer these challenging questions and that go about it, adding to the information that we have, to the body of literature that is out there as we press forward to try to understand truly the best way to take care of our patients. And I agree, I do think this is a helpful addition to that understanding. And with that, I would like to thank both Katie Gutenberg and Lynette Neiman for joining us for this month's edition of Endocrine Feedback Loop. I hope that you all, as our listeners, enjoyed and benefited from our conversation, and I hope that you will look for next month's edition to be released in mid-August.
Hello, I'm Aaron Lohr, host of the Endocrine News Podcast. In addition to bringing you the latest research breakthroughs and clinical advances from experts in the field, we talk about education, advocacy, career growth, and more from the endocrine perspective. From bench to bedside, from graduate school to practice, from the doctor's office to Capitol Hill, we talk about it all, and it's free to you. So go to www.endocrine.org/podcast or search for Endocrine News Podcast on Apple, Google, or wherever you get your podcasts.